dear colleagues, and it gives me immense pleasure to welcome our colleagues from South Korea to this joint webinar session with Indian Academy of Echocardiography. I welcome all our colleagues from Korea who are joining us from across Southeast Asia. So just a brief about the Indian Academy of Echocardiography. You're probably aware it is one of the largest society of echocardiography in the world. We have more than 3,500 plus members and actively involved in promoting cardiac imaging, particularly echocardiography. And in that effort, we have been hosting these webinars on a monthly basis with different organizations, different societies, which have been quite popular amongst the viewers and widely appreciated for the contents. So this time it is a honor and a pleasure to host this particular webinar in collaboration with the Korean Society of Echocardiography. So we have esteemed guests from the Korean Society. I welcome the president of the Korean Society of Echo, Professor Hae Ok Jong, and very good evening, sir, from India. And I invite you to please take forward and introduce the colleagues from Korean Society.
Good evening, all Korean members, and good afternoon, all Indian members. Welcome to the first KSCA IAE joint webinar. I am Dr. Haeok Jung, chairman of KSC. Our KSC have about 3,000 members. So first of all, thank you all of you for joining us today, even on Sunday. So thank you. I would like to express my special thanks to Dr. Songji Park and Dr. Rahul Mehrotra for organizing this wonderful webinar. So I hope today's program will be inspiring and fruitful for everybody. Thank you.
Thank you, sir. And I would request you to introduce and please take forward the proceedings in collaboration. So the first speaker would be from the Korean side.
Yes.
Yes.
So let me introduce first speaker, right?
Yes, sir.
Yes. I will introduce today KSC IAE joint webinar. Dr. Hyungyun Kim from Sejong Hospital, Incheon, Korea. Dr. Kim, are you ready?
Please unmute yourself, Kim.
Okay. Please go ahead, Dr. Kim.
Thank you, Chairman. Can you see my slide?
Yeah, we can.
Okay, thank you. Good afternoon, everyone. My name is Hyungyun Kim from Korea. Today, I will present several real-world cases of genetic cardiomyopathy. Okay. Case 1 is a 51-year-old male who presenting with chest pain and palpitations. Case 2 is a 22-year-old man complaining only of palpitation. Both patients had normal coronaries, but their ECG and Holter findings suggested arrhythmia. Non-sustained VT in the first case and supraventricular VT in the second case. So we did exercise testing, showed a normal response with case 1, but in the case 2, there was a paradoxical BP drop at stage 3. So let's take a look at the echocardiography. As you can see in here, both patients present with the thickened alveoli. So case 1 showed small LV cavity and alveolar obstruction, typical phenotyping psychomeric HCM. septum was 19 millimeters. And case 2 had a hypertrophy involving septal posterior, and especially you can see here the posterior lateral and inferior wall. We can see the mesh-like lesion, hypertrophy lesion, and you can see that in the apex there is a thickened LV apex, and also we found the RV apex, and which is suspicious for the combined LV non-compaction cardiomyopathy. In the MRI image, case 1 showed a basal to mid septal late gadolinium enhancement, which is a classic HCM pattern. You can see the total LG score was 10. And in the second case, you can see that there is a hypertrophy of LV, but there's a less late gadolinium enhancement. It is confined only to the septal wall. Let's take a look into the role of genetic test of patient. First, we can identify a causal mutation in about 50 patients. 51% to 60%. And second, genetic tests help distinguish true sarcomeric HCM from the phenocopies such as Danon disease, Fabry disease. And the third, it does not necessarily correlate with a higher clinical risk. So it is not a tool for risk stratification yet. And finally, proben testing allows us to determine the whether relatives are also at risk or not. Here is the process of cardiac genetic test. We first analyze proben's gene, and if a causal variant is identified, cascade testing is performed in the first-degree relatives, with the overall diagnostic yield was 30% to 50% only. Back to the case, we performed whole exome sequencing with buccal swab, so it revealed a likely pathogenic TPM1 mutation involving the thin filament. Although it is rare, TPM1 variants are also known to cause variable clinical presentation, and which is a potential sudden cardiac death risk. And for the case 2, we further investigated. So he had a familiar history of heart disease and hearing impairment. And so we suspicious with the Fabry disease. So we performed enzyme test, but it was normal. So we proceeded further genetic test. And with the whole exome sequencing, we identified that he had a pathogenic TPPN11 variant, confirming Noonan or Leopard syndrome. So on the physical examination, we found multiple lentigens, ocular hypertelorism, and low-set posteriorly rotated ear of this patient. So these characteristic features, together with the genetic finding, confirmed the diagnosis of Leopard syndrome with HCM, which is clear genotype-phenotype correlation. Let's move to the next case. The case 3 involved a 43-year-old man with aborted sudden cardiac death. Echocardiography shows asymmetric septal hypertrophy, and genetic tests showed pathogenic MIBPC3 mutation. This is one of the most sarcomeric HCM variant. So this is a flow chart from 2020 ACC guideline, how to integrate genetic and clinical screening. So if disease-causing variant is found, cascade screening is performed. And if there are variant negative, no further testing is needed. And genotype positive but phenotype negative individuals should undergo periodic ECG and echocardiography every few years. For case 3, first-degree relatives were tested and all were genotype negative, so no further testing is required. And this is the final case. 64-year-old man showed asymmetric septal hypertrophy, but non-obstructive physiology. And MRI revealed a patchy midwall, LGE here. And we did genetic testing, and it revealed the pathogenic MTTL1 mutation, which is consistent with mitochondrial cardiomyopathy. This mutation accounted for 80% of MELAS phenotype. So we confirmed the diagnosis with HCCM due to mitochondrial cardiomyopathy. And this variant has been previously reported as a part of MELAS spectrum, but in this patient, the manifestation was limited to cardiomyopathy. So future treatment target the genetic cause of HCM. So identifying the genetic cause of HCM is not only diagnostic, but also guide future treatment strategy. So this is the last slide. In conclusion, careful history taking and physical examination remain essential to detect Sutter syndrome features in genetic cardiomyopathy. Multimodality imaging and targeted genetic testing confirm the diagnosis and enable family screening. Understanding the genetic background supports individual surveillance and opens possibilities for future gene-based therapy. Thank you for your attention.
Thank you, Dr. Kim, for your excellent presentation. You present 4 cases of HCM. Okay.
Thank you, Dr. Kim.
Is there any question or comment?
No, at the moment there are no questions. So we move ahead with the next speaker. And
okay.
My privilege to invite Dr. Rishikesh Shah from India. He's a consultant non-invasive cardiologist at Jupiter Hospitals in Mumbai, in India. So over to you, Dr. Shah.
Okay. Good evening, everybody. Good evening to my friends in India as well as South Korea there. I hope I am audible as well as my slides are visible.
Yes.
Yes.
Yes. Okay. Thank you. Let's go ahead. I'm presenting a couple of cases and interesting ones. So is a 42-year-old male who presented with dyspnea on exertion class 2. He was a non-smoker, non-hypertensive, non-diabetic. ECG showed LBB like IVCD, intraventricular conduction defect, and he was referred for echo. And this was his parasternal long axis view. You can see one is colored image and another is a non-colored one. You see there is a bit of MR, and you see the infralateral wall or the posterior wall showing multiple projections into the LV. But let's go ahead. Let's see the other views which will help us. Okay, now this is the view. This is our apical 4-chamber view, which you can clearly see in the infralateral wall. You can see there are multiple projections here which are seen coming out into the LV, which are causing like crypts, multiple crypts also there. The lateral wall essentially looks more smoother, but let's go ahead. This patient also, if you can notice, has bit of dysynchronous septal motion consistent with LBV type of IVCD. These are the short axis views at the level of mitral wall, at the level of apex, and at the papillary muscle level. Again, showing the similar findings of multiple projections into this. Yeah, we put color interrogation after that. You see there is no VSD as such, but there are definitely multiple spike-like projections coming into the LV, and blood is flowing in and out through them. Same thing here. Now we use a lot of contrast at a place. We used contrast to see if we can, have any other important findings. Here you can see the contrast actually enhances and clearly delineates the endocardial border. Now you can see these projections, which are multiple. They are very coarse. They are not very fine. And surprisingly, on the lateral wall, earlier, which we used to get saw it as a smooth, here also you see there are multiple projections coming from the lateral wall as well. So whole of the LV, there are multiple projections there, including the apex, okay? And the LV is definitely depressed. So this earlier we thought initially as a non-LV compaction myocard, but then definitely this was all compacted. There was no non-compaction to compacted myocardium, which we typically get as in 1:2 ratio. This is the same contrast echo finding. And this is non-contrast and contrast. In this non-contrast image, you can see the lateral wall looks pretty smooth and there's nothing there on the plain echo, but after giving contrast, you see there are actually multiple projections on the lateral wall also. The patient did not have much of diastolic dysfunction. We did a 3D also, and 3D showed us actually there are multiple this shelf-like projections muscular, which are not complete, but incomplete projections, which are extending from septum to lateral wall. This is again the 3D finding, which we are looking at the septum en face. And then we did an MRI. MRI also confirmed the similar findings which we had. This is SSFP's images of the MRI. There also you see there are multiple projections here, here, here. They are very coarse. They are not very fine. And you see whole of this myocardium is compacted. It's perfect. And then these are the short axis cuts of the MRI, again confirming the similar findings. These are the late gadolinium enhancement, and there was no late gadolinium enhancement in any part of the LV whatsoever. So basically, cardiac MRI did confirm our diagnosis, and it did not show any gadolinium. So no fibrosis was seen on this. So what is this? So this was nothing but a new entity known as sawtooth cardiomyopathy. So sawtooth cardiomyopathy is an unusual type of LV dysplasia that characterized by multiple projections of compacted myocardium that makes the appearance of sawtooth. It was initially falsely reported as variant of LV non-compaction. While in sawtooth cardiomyopathy, there are numerous projections of compacted myocardium is noticeable, and in LV-NC, prominent trabeculated meshwork can be seen. Only 6 cases have been reported in the literature with this specific entity. They report the presence of septal dysplasia and muscular bridges between the inferior and lateral wall, which we showed on a 3D echo as well as on the MRI. Even though sawtooth cardiomyopathy has been described in adults, the first case reported was in 2-month-old infant, suggesting a very early and probably prenatal development. Also reported in elderly, suggesting a very benign course. All of the reported cases were male participants. That raises the possibility of X-linked disorder. But since there are not many cases, it is relatively new cardiomyopathy to study. Not much has been studied up till so far, but down the line probably we'll have much of the literature. These are the various references from where we have taken this. Let's go to our next case. There was a patient with abnormal ECG echo. He had come for an echo as just a routine pre-employment checkup. He was young diabetic, no history of chest pain or acute coronary syndrome, no history of arrhythmias or syncope, no history of TB or rheumatic heart disease, no family history of cardiomyopathy or sudden cardiac death. This was his ECG. The earlier ECG was showing LBB type of IVCD. This shows more of an RBB type of IVCD. The chest X-ray showed a normal cardiothoracic ratio, no cardiomegaly. And this was his echo. You can definitely see the LV is depressed for sure. We'll go to further images. And here you see, this is a short axis view at the level of mitral wall. And you can clearly see there are these projections coming out from the septum And then this is aneurysmal bulges, which you see. One is towards the inferior septum, one is towards the anterior septum. They are actually going out. They are dysplastic. They are not contracting, but relaxing when the LV is contracting. And we again put in color there. There again, the blood is flowing, but there's no VSD, anything. And similarly, you can see those are extending below also when you go towards the apex. This is the four-chamber view. You can see here, unlike the earlier echo, here the LA is quite dilated. And definitely you can see that in inferior septum, there is this aneurysm which is coming and going. LA was definitely significantly dilated, with the patient definitely had a raised. Here you can see the pH quite severe enough with a congested eyes. So this was more of a grade 3 type of diastolic dysfunction. Now in this patient again, the same thing which we will show. Yes. We go further. We did an MRI again. MRI to confirm the diagnosis. It again showed similar things with multiple projections along with it. Those aneurysmal thing on the anterior septum as well as the inferior septum, which comes and goes. You can see here, which is dysplastic. These are the MRI images again. And this patient definitely showed gadolinium. Definitely he had some amount of gadolinium there. You can see this. Yes. Now we did a genotype in this patient and we did a genotype of all the study. But in this patient, he had turned out to be positive for ANK2+. Now the question, we did not know whether this has any causal effect or there has been no proven this thing, but just as a part of the routine testing for cardiomyopathy, we found, but there is no cause effect relationship has been established as of now. So I'll leave it there. Thank you.
Thank you, Dr. Rishikesh, for these wonderful images and moving.
You want to have questions in the end for the discussion?
We had just one question. If we have time, I think we can take it up amongst ourselves.
Okay.
How is it different from non-compaction cardiomyopathy? I think what they want to know is, how do you differentiate number one echo or clinical course also? Is it different than non-compaction?
Yeah. So yes. So non-compaction basically, and I remember here, non-compaction, the whatever trabecular you are getting, they are very fine. You get a distinct distinct compacted and non-compacted myocardium with a ratio of roughly 1:2. So where a non-compacted myocardium is 2 and here is 1. Here you can see the distance between those muscular projection is significantly higher. In non-compacted, they are very, very near. And here you can see that whole of the myocardium, the projections which were coming were all compacted. While in non-compacted, you can differentiate between a non-compacted upper thick layer and a compacted thin layer, which is outside. So, this is definitely not LVNC, which we need to understand. This is a different entity altogether. Earlier, many people confused it with LVNC, but this is not LVNC. You can see there were multiple projections, but they were very coarse. You see the projections, the distance between them is also significantly higher. In non-compacted, you see very fine projections and which are very, very close to each other. And then a non-compaction and HCM also bears a similar genetic history. They say that they are actually, the two ends of the same spectrum. On far end is the full-blown HCM, while on one end is the non-compaction. So somewhere in between this is there. But this sawtooth cardiomyopathy is altogether different. Now, whether what it is it X-linked, whether it is any genetic correlation with it, we still need to investigate it. As of now, not much studies have been done.
Thank you so much for the elaborate answer.
Beautiful utilization of multimodality imaging, and the contrast imaging was also very beautiful, and it was, showing good relationship with the MRI images. So Excellent case, Dr. Rishikesh. Over to you, Rahul.
We can have a third case in today's webinar from our South Korean colleagues.
Okay. Do you hear me well?
Yes.
Yes. I'm sorry I'm a little bit late. I'm Dr. Sang Chul Lee. I'm the Secretary General of Korean Society of Echo. And I'm proud to introduce Dr. Sori Kim, Kim Sori, from Korea University. She has been working with us at Samsung Medical Center until she became a faculty member in Korea University, Seoul, Korea. And she will be talking about ICI-induced cardiomyopathy. So I hope this is going to be another interesting topic. Dr. Kim?
Thank you, Dr. Lee, for kind introduction. I'd like to share my slide. Do you see my slide? Okay.
Yes, we can see.
Okay. I like to present a case of a 63-year-old man who was admitted for general weakness and anorexia. And he had a medical history of sigmoid colon cancer with lung and liver metastasis, which was treated with nivolumab in combination with ipilimumab. On physical examination, his vital signs were stable, and he showed regular heart rhythm without any audible murmur. ECG shows normal sinus rhythm, and chest radiograph showed no cardiomegaly. Initial laboratory findings showed no anemia, no renal dysfunction, no abnormalities in liver function test, but there was elevated cardiac enzymes and decreased TSH and increased free T4 level. This is his TT findings 1 year earlier. It showed normal chamber size with normal LV systole function. The initial impression was thyrotoxicosis. During further workup, he developed recurrent fever and he showed elevated anti-thyroglobulin and anti-thyroid peroxidase antibodies. And cardiac enzymes were normalized, and thyroid scan showed diffusely increased uptake. So the final diagnosis was ipilimumab-induced thyrotoxicosis, and the treatment was initiated with methimazole and prednisolone. On hospital day 5, he gained body weight by 5 kilograms and he developed pulmonary edema. And he underwent radiotherapy with a second line of nivolumab on hospital day 5. And on hospital day 5, he developed orthomia. TT image showed like this. There was enlarged LV chamber size and mildly reduced LV systole function and RV dysfunction. And there was regional wall motion abnormalities on mid-lateral wall and mid-inferior walls. LV diastole function was further impaired with increased LV filling pressure and increased RV systole pressure. So the initial impression was ischemic cardiomyopathy versus stress-induced cardiomyopathy, and he was treated with volume control with intravenous furosemide infusion, and a coronary workup for coronary angiography was planned. But on hospital day 8, while returning from the convenience store, he developed ventricular fibrillation And CPR was performed for 30 minutes. And after defibrillation at 150 Joule and 200 Joule, ROSC was achieved. And amiodarone was administered with IV bolus and followed by maintenance dose. Cardiac enzyme was further decreased over time. And the coronary angiography showed no significant coronary artery stenosis. Short-term follow-up TT showed no significant interval change. But he developed recurrent ventricular fibrillation and ventricular tachycardia. And after 4 minutes of CPR and defibrillation at 150 Joule, he regained ROSC was again achieved. So what could be the cause of this decompensation? Immune checkpoint inhibitors are monoclonal antibodies that block intrinsic downregulators of immunity, such as CTLA4, PD1, and PDL1, to induce anti-tumor responses. And it can direct or indirect, it has indirect and indirect cardiovascular toxicities. In this study, ICI myocarditis is quite rare, like around under 1%, but it is often more frequently occurred in patients treated with combination ICI therapy compared to patients treated with monotherapy. And it is potentially fatal. Its mortality rate is around 50%. So when ICI-induced myocarditis is suspected, ICI should be withheld immediately. To diagnose ICI myocarditis, there is clinical diagnosis criterion. So elevated troponin levels with one major criterion or two minor criteria are needed. And major criterion includes CMR findings compatible with myocarditis, and minor criteria include compatible clinical syndrome, ventricular arrhythmia, and reduced LV systole function with or without regional wall motion abnormalities. ICI myocarditis is most commonly occurred within the first 12 weeks after initiating the therapy. And if it's suspected, ICI should be discontinued immediately, and high-dose methylprednisolone pulse therapy should be initiated promptly. So, returning to the case, the patient was finally diagnosed with ICI-associated myocarditis, and high-dose steroid pulse therapy was initiated, and along with guideline-directed medical therapy for heart failure. During treatment, CMR was performed, which showed increased native T1 value and increased late guardian enhancement at mid-wall and increased T2 value. And this was compatible with main criteria of the Lake-Lewis criteria for myocarditis. And during treatment, pulmonary edema improved. And on hospital day 18, he was discharged. On the day of discharge, TT showed no interval change, but the diastolic function improved, and NT-proBNP level became near normal. At 1 year follow-up TTE, the LV systole function was still mildly reduced. And follow-up CMR showed no significant change in T1 level and leg enhancement, but T2 value was decreased. This is the last slide of my talk. And immune checkpoint inhibitor myocarditis is rare but potentially fatal. And clinical suspicion and multidisciplinary approach are essential for diagnosis. And diagnosis integrate clinical syndrome, biomarkers, ECG, and imaging findings. And if once suspected, we should stop ICI immediately, and we should start steroid therapy promptly. So thank you for your listening.
Thank you so much. Very interesting case, particularly the way life-threatening ventricular fibrillation was detected in a timely manner and treated effectively. We have a question in the chat box. Was GLS utilized to aid in the diagnosis or at any point of time? Global longitudinal strain?
Oh, actually, the GLS was also decreased in this patient, but actually this patient has apparently, had regional wall motion abnormalities and reduced LV systole function. So the GLS is kind of additional findings.
Thank you. Thank you so much. We don't have any more questions in the chat box. I think we can move to the next speaker, who's my colleague, Dr. Arif Mustaqim. He's a director of non-invasive lab at Max Super Speciality Hospital in New Delhi. So I invite Dr. Arif Mustaqim to talk about his case on Danon cardiomyopathy. Dr. Arif, please start sharing your slides.
Thank you, Dr. Rahul. And just let me start the sharing of my screen with. Can you see my slide?
We can, yeah.
Yes. Good evening, everybody.
Put it on slideshow, please.
It's not in the slideshow?
No, please go to the slideshow mode.
Okay. Now
good.
Okay. So I present to you one of my interesting case. This was a 15-year-old boy, and he was asymptomatic till 12 years of age, and he was studying in class 7th. He complained of shortness of breath for last 3 years, and this dyspnea was initially grade 2 to 3, and it has worsened over last 3 months. And after evaluating for other causes of the dyspnea, when we were not able to get anything and there was no other significant past medical history, so we moved to the next thing, and clinical examination. There was no pallor, no cyanosis, no icterus, jugular venous pressures were normal, liver was not enlarged, and there was no peripheral edema. And pulse was 90, BP was 104, 70, pulse rate, respiratory rate 24, SpO2 99, and weight was just 40 kg. And in the clinical cardiovascular examination, apex beat was present lateral to the mid-clavicular line in the 6th intercostal space. S1 and S2 were normal, and there was LV S4 present in this particular patient. And in the family history, he was the first person to have been affected by a similar disease. And in the investigation, when we did the ECG, so ECG was quite classical, that we can see that there is a delta wave present here. And so this ECG in the image shows ventricular pre-excitation with the short PR interval and delta waves consistent with Wolff-Parkinson-White pattern. And there is also evidence of left ventricular hypertrophy So there were the two things which were a combination, which were pointing towards a certain pattern. And then we had the X-ray of this patient, which showed cardiomegaly. And important thing in this X-ray was that there was no obvious pulmonary edema or pleural effusion in this case. So, and if we see this particular slide, in the blood investigations, we can see that platelets were okay, hemoglobin was fine, but thyroid function was normal, BNP was definitely raised and quite a bit. And the other thing was that CPK was raised in this patient, CPK-MB was raised, lactate was normal, myoglobin was significantly high, and LDH was also high. Now, when we look at the echocardiogram in this patient, when we see in the four-chamber view, I just noticed one thing in the previous presentation, and I will just like to mention here that I think the left-right orientation of we people in India is slightly different from your orientation of left and right in the echo images. So this is the way we have been doing in India. So we can see that there is a significant left ventricular hypertrophy, and there is obvious myocardial dysfunction. Global hypokinesia is there, and the myocardial appearance, echo texture, is also altered. This is another view, again showing especially the septal part. There was a mild MR present, and there was slight mild AR, and this is a short axis view, again showing severe LV dysfunction in this patient. This is para-external long axis view. So all of them were pointing towards a severe concentric LVH in all these images, with marked increase in wall thickness and dilated left atrium and left ventricles, and so there was a definite LV dysfunction in this patient. When we did the global longitudinal strain, we can see that the GLS was grossly reduced in this patient, which is also consistent with the obvious LV dysfunction on the 2D imaging. But what we normally looking for in GLS in majority of situation is whether there is apical sparing or not. So in this particular case, we didn't see any apical sparing. So apex was also involved. Now this is the cardiac MRI of the same patient, and this cardiac MRI image shows marked dilatation of the left ventricle with hypertrophy and thickening of the ventricular walls. And the same thing we can see in the short axis view also. And in the late gadolinium enhancement, there is a diffuse, nearly transmural patchy enhancement of the left ventricular myocardial. So all these features are, and most pronounced is the lateral and the inferior wall. And septum was relatively spared in these images. Then T1 relaxation time. So this T1 values noted 1204 and 1286 milliseconds in the septal and the lateral wall indicate diffuse and pronounced myocardial fibrosis in this particular patient. And so then the biopsy was performed in this patient, and it shows myocyte hypertrophy with the numerous vacuoles within the sarcoplasm of the cardiac myocytes. And then the past stained histopathology image shows extensive intracytoplasmic vacuolization and a strong past positive, indicating abundant glycogen accumulation within the cardiac myocytes. So all these things till now, whatever we have seen, they are pointing towards genetic cardiomyopathy, and the phenotype is the hypertrophic pattern. And in the electron microscopy, there were images of abundant autophagic vacuoles within the cardiomyocytes with contained digested cellular debris and glycogen. So now we come to the discussion, and here we can see that the genetic predisposition is there. This is X-linked and autosomal dominant disease, and this pattern of inheritance is a classical pattern in Dannon's cardiomyopathy, and similarly this ECG pattern. So these findings are characteristics of Dannon's cardiomyopathy, and where WPW syndrome is observed alongside rapid progression of cardiomyopathy. And other arrhythmias are also present, but this WPW syndrome is classical for these patients. This pattern, especially in the context of young patients with a family history and other clinical features, which I'll just mention in the next few slides, that strongly suggests the possibility of Dannon's cardiomyopathy. And here in this image also, if we see these features of left ventricular hypertrophy, LV dilatation, LV dysfunction, these features are typical of Dannon's cardiomyopathy, where severe concentric left ventricular hypertrophy is present. And when the disease progresses, dilatation may develop with the disease advancement. The image appears aligns with the phenotype type, because this is the hypertrophic variant, and there is another variant where you have a dilated pattern. And on the gadolinium enhancement, this pattern is again highly suggestive of extensive myocardial fibrosis, which is a hallmark of Dannon's disease, and it distinguishes from other hypertrophic cardiomyopathy. And again, T1 relaxation time, we just noticed this increase shows significant fibrosis in this patient. So in patients with Dannon's, there is diffuse thickened left ventricular valve, and patchy or transmural late gadolinium enhancement, elevated native T1 and T2 values, and global or regional strain abnormalities. And there is progressive decrease in ejection fraction. Histopathology, we just noted, and electron microscopy, there are a few red flags for Dannon's. Early onset severe left ventricular hypertrophy, rapidly progressing, and along with dilatation and systolic dysfunction in adolescents or young adults, especially males, and electrical pre-excitation in combination with severe cardiomyopathy. Imaging or biopsy evidence of vacuolated myocytes and LAMP2 gene mutation is the confirmation. And these findings taken together, particularly the combination of ECG pre-excitation, severe and rapid progression of LVH or dilated cardiomyopathy, especially in female patients, and characteristic CMR features should prompt suspicion of Dannon's disease and confirmatory diagnosis by the genetics. So this was one of the case. I think these rest of the images, which were the guidelines of 2023, these were discussed with by our earlier colleague. The bad thing about the disease is that a lot of time we don't have much to do about these patients except for the cardiac transplant, and at certain stage heart failure is there, so you manage the heart failure in these patients. If the arrhythmias are going on, then medical or intervention electrophysiological management of these arrhythmias can be taken care of. And along with this, the combination is that there is a neurocognitive disorder in these patients. There is visual retinopathy is there, and skeletal, especially proximal muscle abnormalities are present in these patients, and anxiety and mood disorders. So this is a combination of non-cardiac structures in the body along with the cardiac involvement, which prompts us to this particular deadly disease. The research is going on, and we hope in time to come we will have some solution and some hope for these patients. Thank you. My presentation is over. I open to any question.
So thank you, Dr. Arif, for a very elaborate presentation on covering all aspects, including the histopathology images, even sharing the electron microscopy images and the cardiac biopsy. A very interesting case. So there is one question, since I would like to thank all the speakers for finishing well within the time. So we are left with a good amount of time for some discussions. If there are any questions from our colleagues from Korea to the speakers, let us ask them.
Actually, I have one question for Dr. Arif.
Yes.
And you said heart transplantation is the only treatment for Danon patients. How about the clinical course after heart transplantation for this patient? Is it okay or?
Actually, till now, the number of patients is very little. And so no modality of treatment has been offered to large number of patients, because a lot of time when these patients are presenting, they have other ailments also. And so there is not much data available to answer whether this particular modality of treatment has worked or not. But at this present situation, because there is no other solution for these problems, so heart transplant is suggested as one of the methods.
Agreed, because even the transplanted heart will undergo the effects of this, and ultimately even that is likely to fail. That is, I think, was the point of asking this question by Dr. Kim.
So there is some question from the Indian Society of Echo to the Professor Kim. Kim. So here is the should echo be done in all patients on ICI-induced cardiomyopathy in South Korea? Is it the question?
Thank you for the good question. And actually, in ESC cardio-oncology guideline, high risk patients like who underwent combination ICI therapy, they should undergo transthoracic echocardiography at baseline. But actually in Korea, transthoracic echocardiography is very cheap and very accessible. So I think almost most of patients underwent ICIs, actually underwent TTE at baseline and during follow-up, actually.
Thank you so much. And we can say to you that even in India, echocardiography is quite accessible to most of our patients and quite affordable also. So most of our patients are able to get their echocardiography done wherever required.
I think for any patient going for chemotherapy of any sort is definitely undergoing an echo imaging before the procedure starts. And then I think before every next dose, they again come back and for an echo with this strain imaging.
Right. We have one question for Dr. Shah, Dr. Rishikesh Shah, about the sawtooth cardiomyopathy. Viewer has asked that can we consider interventricular dissection in your second case?
No. Interventricular dissection is an altogether different ballgame. You can see dissecting a membrane there, a separate membrane. Normally, you get more of commonly with an LA dissection rather than an LV dissection. But yes, dissections can still be there, but it will not be so globular with multiple shelf-like structures. And in 3D, you can show actually the band-like structures moving from lateral wall to septal shelves like. And this is not definitely, you cannot mistaken this as an LV dissection for sure.
So what would be the diagnosis for your second case? What would you label it as?
Yeah, so I mean, we would also label that kind of as a sawtooth thing with early kind of thing of you can formifrusty kind of thing with an LG. The basic point to make to show me the second case was it shouldn't happen to think that this is all benign thing, nothing needs to be worried. there is a plethora, like it is a spectrum. Probably in some cases there is no LG. So in some cases it may behave benignly, but in few other cases it may behave as malignantly or as dangerously with extensive fibrosis and dysplastic LV features kind of thing.
We need to follow it up with
Follow it up, yeah, regularly follow it up. That is the crux of the criteria. That's
So I have question about the sawtooth cardiomyopathy to Professor Sa. So in my expectation is a major complication and long-term follow-up complication of the sawtooth cardiomyopathy. It would be arrhythmia, or is arrhythmia, and but the first case is the RBBB, and second case is the RBBB.
Yes.
And so, are there any percentage of the development arrhythmia in sawtooth cardiomyopathy, or is the sawtooth cardiomyopathy involved in the interventricular septum? So, how much patient develop the mitral valve dysfunction?
Okay, so two questions, two things I would like to say. Yes, what you are telling is right. We also thought the same thing, whether this patient would develop any kind of arrhythmias. So when Holter monitoring was done, there was no question of tachyarrhythmias in any of these patients, and whatever interventricular conduction defects this had, like as I said, in earlier patient was LBB type of thing, in another was RBB type of thing, that persisted. So it did not progress to a complete heart block or something. At least the follow-up which we had, these patients did not progress. Now coming to the second question, whether it had this globular elevation, especially the septal affection, has lead to and mitral wall dysfunction with this. As you saw in first case, there was a bit of MR there, but then significantly, it did not have direct effect on the mitral wall as such, which you normally get in hypertrophic cardiomyopathy with papillary muscles which are malaligned, and that can cause kind of thing. But in these patients there was nothing like that. There was a slight amount of MR there, and which probably we would get in any kind of normal people also at times. So I don't know whether there is a correlation between the septal projections with this MR, but as of now we couldn't identify anything.
So I have a question for Dr. Raul. I see in the presentation that even in most of the cases, cardiac MRI is very much used and very much utilized. So I'd like to know, but in Korea, that's not actually the case, because cardiac MRI is not that often used. They are only used for specific cases, not even in specific like unusual cases in some parts of the country. So what is it like in India in terms of use of cardiac MR? Is it widely used all over the country, or is there like and what if so, what is the limit that is causing its spread?
So a wonderful question, sir. Unfortunately, what you saw was not an exact representation of the entire country. These were rare scenarios, and they wanted to investigate fully. So they went ahead and did a cardiac MRI. Cardiac MRI in India is available, like both the cases were from, one was from Mumbai and one was from Delhi. So cardiac MRI is quite easily available, accessible, and affordable to people in metro cities. But I agree with you that just like in Korea, it is not so widely available across the country in smaller towns and cities. More than availability, what is lacking is a training about cardiac MRI in particular, and correct interpretation of the findings. So that is confined to bigger cities like Mumbai, Delhi, or the metropolitan towns. And wherever required, we refer these patients to higher centers, and it's quite affordable that way.
Well, India is such a large country, and you have so many hospitals, so many people. So I'm sure it must be different in all over the country. But so it is the same, more or less the same in Korea. In bigger centers, MRI is more widely used. but in rural centers, it's not that widely used. So, what is the well, yeah, I leave it to the other doctors for like the other questions. Thank you.
Okay. So we have finished with the questions, I think, and also with the time. So it was a pleasure being with all my colleagues from South Korea. Wonderful presentations. All the presenters did justice.
I have one question, if I can. Yeah,
Yes, please.
to Suri Kim, Dr. Suri Kim. Yeah, I wanted to know, you did a cardiac MRI and you showed that there was an LG which was mid myocardium. Now, normally in myocarditis, you usually get a subepicardial LG. And you also showed that this patient actually improved the LV function, although it did not normalize completely, but the LV function improved. With such myocardial LG, mid myocardial LG, how do you correlate that with that improvement? I mean, so that means, did you plan to do a subsequent MRI? Because if there is so much of fibrosis, how could this be? Or do you have something else also in things in the mind? That's what I wanted to ask. Please.
Oh, thank you for your nice question. And actually, yeah, it's not a typical case of myocarditis. Typical case of CMR finding of myocarditis. Actually, it was mid wall, and actually, these patients' LV function was not that improved. Actually, during follow up, it was a little. It was similar. Yeah, similar to the baseline. So yeah, I think because of the fibrosis already developed at first, so the LV function was not that improved. So actually, yeah. But as long as I know this patient is on the GDMT, yeah, even though the heart function is not that improved, yeah. And I think there's one question for Dr. Kim in chatting, and any experience with mavacamten in
Hypertrophic cardiomyopathy. Yes. Any experience with mavacamten in hypertrophic cardiomyopathy?
I believe most of you have more experience than me, but in my case, I didn't experience the LV decrease, and the LVOT obstruction was relieved just after I prescribed. So I use it for many patients who had a symptom.
And then LVOT obstruction is not resolved by beta blockers.
Dr. Kim, I also had a question. You showed all the cases genetic workup. So, is it your very low threshold for going ahead with gene testing in all patients of suspected cardiomyopathy there? Because gene testing is a big, it's quite an, you can say, an expensive thing to do. So, I mean, how do you go about it? Like, do you do it in every patient suspected of it?
Yeah. In practically, it is way expensive in Korea also, so we cannot do it often. But we have some special program with some company who sells Fabry's disease. So we use it because we need to differentiate that with the HCM. So.
Okay. So routinely you don't do it, but whenever it's possible, you try and utilize this. That's what you need to say.
Well, but to tell it well, in fact, I'm the chief. I'm actually the chairman of the Korean Working Society of Hypertrophic Cardiomyopathy, and our society actually urges all the doctors to try to perform genetic testing in all of the, especially hypertrophic cardiomyopathy patients. In fact, in my case, I try to get all my patients go through genetic testing as much as they can. More or less around 60 to 70% of the patients receive go through genetic testing in my case.
Oh, that's good. That's good.
Could you share some tips to persuade patients to do genetic tests? Because for me, it's really hard to actually persuade them because it's really expensive and they really
The
don't.
key is to try to get them to sit them down and tell them about you've seen me working, right?
Yes, right.
And try to explain to them their cases face to face, like about 15 minutes, 15 to 20. And then they get,
That works everywhere. This
Yeah.
strategy works everywhere.
Right.
Understands, they will likely go ahead with it, particularly if it is important for the future generations and also
For their children.
yes. So thank you so much. I think it's time to wind up. It was a very interesting session that we had. Meeting for the first time, most of us each other. I think this should not be the end. We should continue to interact in different forums and hope to see you all soon on different echocardiography meetings.
Anybody
Thank you
coming
so much.
to Vienna? Anybody coming to Vienna?
From this particular audience, I don't think. No.
That's too bad. Okay, thank you.
It was wonderful. Yeah.
Thank you. And
Okay.
You can definitely come down to India sometimes for sure. We'll be glad to host you here.
invite.
Dr. Zhang, our director, president, do you have any comments? Last comment?
Thank you for all speakers for sharing rare and educational case. I learned a lot. Thank you all speakers and participants. Thank you.
Thank you.
For taking out
Thank
time.
you.
Thank you.
Thank you.
Thank you.
Okay.
Thank you.
Bye
수고했어요.
수고하셨습니다.
감사합니다.
Bye.